Hey everyone, welcome back for another deep dive. Today we're taking a closer look at something pretty fascinating, at least for us pathology nerds, and that is prostate specimens.
Oh, always a fun topic. We're going to be talking about two main specimen types.
Okay,
We got the TURPs, those little pieces of tissue removed for BPH and things like that. And then the more radical prostatectomy, the whole prostate gland, usually for cancer.
we'll be exploring how these specimens are handled, examined, and the critical information they provide. Plus, we'll uncover why just looking at a prostate isn't always enough to spot those sneaky tumors.
It's true. Visuals can be deceiving. So a pathologist's trained eye, and sometimes even their sense of touch, are crucial for accurate diagnosis.
Okay, so first up, let's talk TURP, transurethral resection of the prostate. TURP specimens bring up a key challenge.
Okay.
These chips are strips from along the prostatic urethra, so getting a complete picture of the prostate is tough.
Which makes you wonder, why is TURP still so common if it's so limited?
That's a good question.
I mean, what are the patient implications here?
Well, TURP is generally less invasive and has a shorter recovery time than other procedures, like a radical prostatectomy.
Okay.
So it's often used for men with less severe symptoms or who are not good candidates for more extensive surgery.
Right. And what we get in the lab is a collection of small, uniform pieces, usually grayish tan, kind of rubbery and soft. These TURP specimens, they really demand a keen eye for detail.
Almost like a detective searching for clues, right?
Exactly. We're looking for any subtle changes in color or texture, like patches of yellow or orange. Those can be a red flag for cancer.
Oh, wow. So even slight color variations can be significant.
Hmm.
Now, are there specific guidelines on how to handle these TURP specimens?
Definitely. The College of American Pathologists, or CAP, has guidelines to ensure we're examining them thoroughly. Typically, we submit the first 12 grams in total. Then, for every additional 5 grams, we submit another cassette.
Makes sense. So nothing gets missed. But I know things can change based on the patient, right?
Oh, absolutely. Things like the patient's age and their PSA levels can lead to variations. Say, if a patient is under 60 and has a PSA level of 10 or higher, we might just submit the entire specimen.
It's incredible. I can only imagine the patience it must take to examine all those little chips under a microscope, making sure everything is...
Absolutely perfect.
Got it. So it's to ensure we're not missing any potential signs of trouble, especially with those tricky occult carcinomas we sometimes encounter.
Exactly. Those unexpected cancers can be hiding in seemingly routine TURP specimens. That's why that meticulous examination is so important. And sometimes we even use palpation.
Wait, palpation? You mean actually feeling the tissue?
Exactly. Visual inspection is only the first step. We also use our sense of touch to feel for any nodules or firm areas that might not be obvious just by looking. You see, prostate tumors can be very subtle. They often blend right into the surrounding normal tissue.
Wow, so you're using your fingertips almost like you're reading Braille, searching for those subtle bumps or inconsistencies.
You got it. It adds another layer of scrutiny, helping us pinpoint those areas that need a closer look under the microscope.
All right, let's move on to talking about the other specimen, the radical prostatectomy.
Yes.
So we're not dealing with little chips anymore. This is the
big show.
Yeah.
This is the whole prostate gland, and it's often walnut-shaped. The source material mentioned a specimen that was 34 grams. That's quite a bit larger than the average 20 grams. And often it's still attached to the seminal vesicles and the vas deferens.
So this is a much larger and more complex specimen. Where do you even begin with something like that?
So the most important thing is orientation.
Okay.
You have to know which part is which for accurate diagnosis and staging. And, things can get confusing with the prostate.
Oh, really? How so?
So the base of the prostate, that's the part that connects to the bladder, is at the top. And the apex, that's the part that's connected to the urethra. That's at the bottom. So it's almost like it's upside down.
Oh, wow. That's significant. So what's the first step when this whole prostate arrives in the lab?
Orientation and inking. We have to be meticulous about this. It involves using different colored inks to mark the right and left sides of the prostate. This ensures everything stays accurate throughout the analysis. This one mentions blue for the left and green for the right.
I see, like creating a map, so you know exactly where each part came from. But I know that can vary, right? I've even heard that some hospitals use 4 different colors.
Yeah, I mean, anything that enhances clarity and accuracy is good. The important thing is consistency, especially when you're dealing with this kind of information, right?
Right, makes sense. Now, I think it's worth highlighting those different prostate zones: central, peripheral, transitional, and periurethral.
They tell a story about what's going on in the gland.
Exactly.
And like you said earlier, where a condition develops can make a big difference.
Exactly. Take benign prostatic hyperplasia, or BPH.
Right.
It loves to hang out in those central and transitional zones.
Okay.
And think about what those zones surround.
Okay.
The urethra.
Right.
So as the prostate gets bigger, guess what gets squeezed?
The urethra.
Yeah.
Which explains why BPH often leads to those classic urinary symptoms.
Exactly.
Difficulty starting a weak stream, all those fun things.
Exactly. But here's the thing. BPH is super common, especially as men age.
Right.
We're talking nearly 90% of men over 80 will have some degree of BPH.
Wow.
But it's not cancerous.
Which is good news, obviously.
Yes.
But if it's so common and it's not cancer, why all the fuss?
Right.
I mean, when does it actually become a problem that needs treatment?
Well, think about quality of life.
Okay.
If you're getting up 5 times a night to pee,
Oh, yeah.
or you're constantly worried about accidents,
Right.
that's going to have a real impact.
Right.
And there are effective treatments, from lifestyle changes and medications to procedures like the TURP we discussed earlier.
Speaking of things that can cause problems, let's talk about the big one.
Okay.
Prostate cancer.
Yeah,
I know it's the most common cancer in men,
it is.
and it tends to arise in that peripheral zone,
Right.
making it easier to catch with a digital exam. In the next part of our deep dive,
We'll explore a more in-depth look at prostate cancer and grossing.
get ready for a whole new perspective.
Welcome back to our deep dive into prostate pathology. What's next on our deep dive agenda? So, now the prostate is all inked up.
Yeah.
It's time to start dicing, I guess. But here's the tricky part. Identifying those tumors just by looking can be incredibly difficult.
Yeah, very tricky. It's not like breast tissue, where a tumor usually feels quite distinct. Prostate tumors, they're subtle. They can blend in with the surrounding tissue really well. That's why we slice the prostate very carefully. Thin slices, about 3 to 5 millimeters from the base to the apex. That allows us to thoroughly examine each section.
And I'm guessing this is another moment where your sense of touch, that palpation, comes in handy.
You bet. Each of those thin slices is carefully palpated, feeling for any firm or irregular areas. Remember, prostate tumors can be sneaky.
Oh, so it's not always visible.
Right, and it's not always easy to palpate. It's really difficult to be able to palpate some of these lesions. You don't have that luxury sometimes in the prostate, but it's very, very important because it can help you find these occult carcinomas.
Wow. So you're really using your hands to get a feel for the landscape of this prostate.
Yeah.
Okay, so palpation helps you zero in on the areas that need a closer look.
Exactly. Exactly. And remember, we want to sample the entire prostate, not just the areas that look suspicious, right?
Right.
So let's say they've got the prostate all sliced up, inked, ready to go. How do they actually analyze those sections?
Well, some labs divide each slice into quadrants.
Okay.
Anterior right, anterior left, posterior right, and posterior left.
Okay.
And submit each one separately.
Okay.
It's all about maintaining that precise orientation.
Right.
Other labs go posterior first from apex to base,
Okay.
and then sample the anterior sections as needed.
So different approaches, but the goal is always to get a thorough, accurate representation of the whole gland. Ultimately, it's all about making sure that no potential cancer is missed.
So it's a combination of visual cues and tactile feedback. Fascinating.
It really is. We're piecing together a complete picture of the prostate, one slice at a time. And if we find something suspicious, then it's off to the microscope for a closer examination.
Speaking of closer examination, let's talk about those surgical margins. Why are they so important in prostate cancer?
Surgical margins are vital. They tell us whether the entire tumor has been removed. We especially focus on the apex and the bladder neck margins. We have to make sure there's no sign of the cancer extending beyond the prostate itself.
I can see how that would have a huge impact on treatment decisions.
Absolutely. If we find cancer cells at the margins, it could mean additional therapy is needed to target any remaining cancer. And the way we examine these margins has even evolved over time.
Oh, really? How so?
Traditionally, we used a radial method, but there's been a shift towards the perpendicular method. It gives a more comprehensive assessment.
That's fascinating. But how do you actually classify the extent of the cancer after all this examination?
That's where the TNM staging system comes in. It's a standardized way to describe how far the cancer has spread. The T refers to the primary tumor. The N is for lymph nodes, and M is for distant metastasis.
So let's break down those PT stages. What does it mean if a tumor is classified as PT2?
So PT2 means that the tumor is confined to the prostate gland.
Okay,
That's good news.
that is good news.
It means the cancer hasn't spread beyond the prostate.
That's a relief.
Yeah.
But what if it has spread beyond the prostate? What are those other PT stages?
So PT3A
Okay.
means that the cancer has extended beyond the prostate,
Okay.
either microscopically or by invading the bladder or neck.
Okay.
And then PT3B
Mm-hmm.
means that the tumor has spread to the seminal vesicles.
Right.
And then PT4 is the
Mhm.
most serious stage. That means that the tumor has spread to adjacent structures like the rectum or the pelvic wall.
Okay, so it's a way to understand the big picture.
Exactly. A higher PT stage means a more aggressive cancer. This often calls for a more intensive treatment approach.
Wow. Okay, so we've covered a lot here, from carefully examining those tiny TURP fragments to the complexities of staging prostate cancer after a radical prostatectomy. It's amazing how much these specimens can reveal.
It really is. And it all starts with those meticulous steps in the pathology lab. By analyzing every detail, we ensure an accurate diagnosis, which ultimately guides the best treatment plan for each patient.
Well, one thing we haven't really discussed is the Gleason grading system. I know it's super important in prostate cancer, but how does it actually work?
The Gleason score. Yeah, it's a cornerstone of prostate cancer diagnosis. Basically, we're looking at how the cancer cells are arranged under the microscope, how organized or disorganized they appear.
Okay.
And that's based on patterns that we see under the microscope.
Okay, so tell me about these patterns.
All right, so imagine you're looking at a neighborhood from above,
Okay.
and you can see all these houses, right?
Mhm.
In a normal prostate, those houses or glands are well organized and neatly arranged.
Okay.
But when cancer develops, things start to look a little different.
How so?
Those houses might be crowded together, their shapes might be smaller, distorted, it just doesn't look as organized.
So you're looking for changes in the architecture of the prostate tissue.
Exactly. And the Gleason score is all about grading those changes.
Basically, pathologists look at the cancer cells under a microscope and give them a grade from 1 to 5 based on how abnormal they look.
Okay.
1 is the least aggressive, 5 is the most aggressive, kind of like a cell behaving badly scale.
So the higher the grade, the more trouble you're in.
Exactly. But it's not just one grade, they actually assign 2.
Okay.
1 for the most common pattern they see, and 1 for the second most common.
Oh,
Then they add those 2 numbers together to get the total Gleason score, which can range from 2 to 10.
so a Gleason score of 10 would be the worst case scenario.
You got it. But here's where things get interesting. We've learned that just looking at the total score isn't always the most helpful.
Right.
So now we group those scores into what are called grade groups from 1 to 5.
Okay.
These grade groups better reflect the prognosis, how the cancer is likely to behave,
Okay.
and guide treatment decisions.
So it's less about the individual numbers and more about the bigger picture of what those numbers tell us.
Exactly. Gleason gives us the personality of the cancer, if you will.
Right. And just like architectural styles have changed over time, the Gleason system has also been refined to give more accurate assessments.
I bet that leads to more personalized treatment plans for patients.
You got it. Tailoring treatment to each patient based on their specific cancer. Great. Let's move on to a fascinating aspect, perineural invasion.
Perineural invasion. That sounds ominous. Tell me more.
So perineural invasion, or PNI, happens when cancer cells are found within or around nerves. This can increase the risk of the cancer spreading to other parts of the body.
Almost like the cancer is using the nerves as a highway to escape.
In a way, yes. And while it doesn't directly impact the PT stage, PNI is still a very important prognostic factor. Studies show that patients with PNI tend to have a higher risk of recurrence and a worse prognosis overall.
That's definitely concerning. So it's another piece of the puzzle that pathologists are looking for when assessing the aggressiveness of the cancer.
Exactly. And it underscores why a thorough microscopic examination is so critical, not just of the tumor itself, but also the surrounding tissues.
Okay, so even though PNI doesn't directly affect the TNM staging, it still gives crucial information about the cancer's potential behavior.
Precisely. We're trying to paint a complete picture of the cancer's aggressiveness and its potential to spread.
This is all fascinating. It really does feel like detective work.
Connecting those dots between what we find in the lab and the clinical picture, that's what ensures accurate diagnoses and effective treatments. Excellent. In the next part of our deep dive, we'll explore the fascinating world of whole mount sections. It's a technique that offers an even more comprehensive view of the prostate gland.
Whole mount sections. That sounds intriguing. Can't wait to hear more.
Get ready for a whole new perspective.
All right, we're back, and ready to keep exploring the microscopic world of prostate specimens. Last time, you mentioned something called whole mount sections. What are those exactly?
Whole mount sections. They're a really cool technique, you know? They let us look at a whole slice of the prostate on one slide. Like imagine a panoramic view instead of just looking at little pieces.
Wow, that sounds amazing. How does that even work?
Well, we need some specialized equipment, larger cassettes, and then a special microtome, a sledge microtome, to handle those bigger tissue sections.
I bet that level of detail makes a huge difference, especially for staging.
Oh, absolutely.
Yeah.
Especially for something like extraprostatic extension, you know, where the tumor might be pushing just beyond the prostate's edge.
So it's like piecing together a giant puzzle. Then, right, you get to see all the connections and patterns. I bet that leads to more personalized treatment plans for patients.
You got it. Tailoring treatment to each patient based on their specific cancer. Now, besides Gleason, we also have that TNM staging system we talked about earlier.
Right, the PT stage is super important, focusing on the primary tumor. It takes into account things like size, location, and spread.
Exactly. Ranging from PT2, where it's confined to the prostate, all the way to PT4, where it's spread to nearby structures.
I remember extraprostatic extension and seminal vesicle invasion playing a role in that staging too, right?
Absolutely. Those are key factors. If the cancer has broken through the prostate's capsule or invaded the seminal vesicles, it's a sign of a more advanced stage. We use the information from the pathology specimen to guide those clinical decisions. It's a strategic approach.
Wow. This has been an amazing journey through the world of prostate pathology. Those tiny TURP fragments, the complexities of whole mount sections, and the nuances of Gleason and PT staging. It's incredible how much we can learn from these specimens.
It is pretty amazing, and it all starts with those meticulous steps in the lab. Orientation, inking, slicing, palpation, microscopic examination. Every step is important to ensure we get it right. We analyze every detail to make sure the diagnosis is accurate, which is what leads to the best treatment plan for each patient. And pathologists, we're like detectives, using our eyes, our hands, and our knowledge to piece together the clues and get the most accurate picture possible.
You know, it's not just us. Our pathologist assistants,
Right.
they play a really big part in all of this too.
Right, because they're the ones who are actually preparing these specimens.
Yeah, absolutely.
Making sure that they're oriented,
Yeah.
inked correctly.
That they're sliced correctly. They're like the stagehands in a play.
Yeah.
They're not in the spotlight, but they're essential.
Right, they make sure the show runs smoothly.
Exactly.
And without them, the pathologists couldn't do their job as effectively.
Couldn't do it. It's a team effort, 100%. And you know what? It's important to acknowledge those people that are working behind the scenes.
Yeah, teamwork makes the dream work.
All right, so we've been talking about teamwork and how important it is, but there's another really important aspect that we need to touch on, and that's communication.
Yes, communication.
So once the pathologist has examined the specimen,
Correct.
they've made all their findings, they need to get all that information to the oncologist
Right.
in a way that they can understand and use it.
And that's where the pathology report comes in.
The pathology report.
Yeah.
That's that document that summarizes all of those findings.
It includes everything.
Yeah.
The tumor size, location, the Gleason score, the margin status, you know, all the
I
observations.
mean, it's like the blueprint
It is, yeah.
for the oncologist.
It is.
So they know how to best move forward with treatment.
Yeah. And it's not just a boring technical document.
Yeah.
You know, it can really shape someone's life. It really is. And remember, this deep dive has just been a glimpse into the world of prostate pathology. There's always more to learn, more to research, and more ways to improve patient care.
It's a field that's constantly evolving, isn't it?
Absolutely. And for someone like you who's already so knowledgeable, I hope this has sparked some new ideas or questions. Well, on that note, I think it's time to wrap up this deep dive.
This has been an incredible journey. I feel like I have a whole new appreciation for the complexity and the artistry of pathology. Thank you so much for joining us on this fascinating exploration of prostate pathology. Until next time, keep those brains buzzing.
And remember, knowledge is power, especially when it comes to your health.